Good evening. Thank you very much for joining us. Just waiting for the last few people to come through the waiting room. So thank you for being with us this evening. This is another of our sessions on Your Care, Your Views. So talking to you about proposals for our 3 hospitals. And this evening we're focusing on the proposed model of care for Hemel Hempstead Hospital. It's not just me tonight, you'll be pleased to hear. I'm very lucky in that I've been joined by Dr. Mike Vanderwatt, our Chief Medical Officer, Claire Parker, our Director of Strategy and Integration, and Dr. Sandeep Ballara, who is a consultant rheumatologist and also has the brief for being Clinical Director for medical specialties. So really good panel tonight. I'm hoping that you have lots of questions for them and that we'll have plenty of time to get to those. So a couple of things about being on Zoom. We ask you to keep your cameras off. That just helps with bandwidth. And as per usual for these sessions, your questions should come to us via chat, and please send them to West Herts Communications. Questions to me or other members of my team won't be seen, so it is important you do send them via chat to West Herts Communications. We are recording this session and we will upload it to our YouTube channel over the next few days. So the aim of this session is to explain the proposals, what we've been doing, why we've come up with these ideas, and to tell you about the engagement. So we want to hear from you, and we will tell you how to get in touch with us. And as I said at the beginning, there will be an opportunity for you to ask questions. A little bit of background. I've seen some familiar names on the meeting tonight, but I've also seen some new names. So I am going to do a little bit of a recap. We've been working for some years now, a lot of our work with our colleagues at Harts Valley's Clinical Commissioning Group, and we've been working to secure funding for major redevelopment. And that is development at Watford General, Hemel Hempstead and St Albans City Hospitals. In September 2019, the Prime Minister, Boris Johnson, announced that we were one of 6 trusts to receive funding as part of the Health Infrastructure Plan. So if you hear us slip into jargon, we'll try not to, but we do sometimes call it HIP 1, just as a shortcut. But new language, because jargon and language is always changing in the NHS, is the New Hospitals Programme. And we are one of 8 frontrunner trusts in the New Hospital Programme, so slight change on the language there. The Prime Minister saying that we have money isn't quite the same as us actually having the money, so we have to do quite a lot of work to get it. And what we're doing now is going through the outline business case, and we are presenting, or we will shortly be presenting, a case to our regulators. So that's NHS England, NHS Improvement, Department of Health and Social Care, and the Treasury. And our case must show overall good value for money, that it is affordable, and that it can be delivered by 2025 or soon after. So if you've been to any of our buildings, you will know that they are not very impressive overall. Hopefully you will have found the care to be excellent, but the surroundings not so, I'm afraid. So going back to Your Care, Your Views, it is a public engagement programme. We are running it until the 24th of March, and we have developed our proposals really starting from a strategic point of view there. So if the strategy behind our proposals is the thing that interests you, please do come up with a question for Claire Parker this evening as she's with us, and do also look on the website where you can read our clinical strategy. Now that document has a more pragmatic partner, the clinical brief, and that's a long document, but it's really good for those who want detail, because it does set out where we envisage delivering services from. And then there are 2 engagement documents, one summary and one slightly longer. And very importantly, there is a survey which we'd love you to fill in, and I'll come back to that at the end. So we have this phrase, three's company. We know the real phrase is two's company and three's a crowd, but we actually do think three is company. We're very proud of our three hospitals, and we think they can work together far better than they are doing at the moment. So we have set about ensuring that each hospital has a unique purpose. But here's a broad outline for what those hospitals would do. Watford General would be the site for emergency specialist and complex care. St Albans is where we would provide planned care, so planned surgical care and planned cancer care, and also an urgent care service. And at Hemel Hempstead, that's where we would provide urgent and planned medical care and to provide treatment for people with long-term conditions. So this is very much what we are doing at the moment, but we want to really refine those roles. And the next slide will show us why. So we have this sort of mantra, consolidate, not duplicate, because we've been talking to our clinical staff about better ways to deliver services. And what's come through very loud and clear is that they are stretched between three sites very often and would really value being grouped together. And this isn't just because they want to be together in bigger teams for the camaraderie. There's good clinical reasons to have your teams grouped together. Firstly, they can work more closely and they can seek second opinions. Junior staff can learn from senior staff. And also importantly is the issue of cover. So if we stretch our teams too thinly across three sites, it can mean that clinics and appointments are cancelled when there is unexpected staff absence. And also having our teams grouped together can really help us make the best use of expensive diagnostic equipment. It also helps us provide one-stop clinics, which is where we try to cover as many stages of your treatment as possible in one appointment. And Dr. Ballara will talk to us a little bit more about that. Underpinning all of the changes that we wish to make is digital transformation. It's already underway. We're at the early stages of implementing the electronic patient record. And so we're excited at the insight that's giving us into how different things will be and how better we can manage your care, because we can access your records in seconds. We will no longer have the issue of clinics being cancelled because we can't find the notes. And importantly, we will be able to share your records with other health professionals who are caring for you once you've given us your permission to do so. We are making the most of virtual appointments, although we've had to move a lot of appointments from in-person to virtual because of the pandemic. We were already looking at that, and we will maintain that as a way of seeing patients. Feedback has been overwhelmingly positive in that people prefer to communicate in this way if there is no real need for them to use our hospital facilities or to see a doctor or nurse or another clinician in person. And diagnostics, of course, also important, and we really want to upgrade our diagnostics across all three sites, including providing some new diagnostics such as a DEXA scanner, which is a bone density test equipment over at Hemel Hempstead. So now I'm going to hand over to Dr. Ballara, who is going to talk to you about our proposals for Hemel Hempstead Hospital.
Thank you, Louise, and thanks for inviting me to just provide a brief overview of the plans for Hemel Hempstead. So that's summarised in this slide. So essentially, Hemel Hempstead, the proposal is that we will be providing urgent care services. Both the range and the volume of care for people with long-term conditions will be increased, and it will become a specialist site for certain specialties such as endocrinology and diabetes and rheumatology, whilst a range of other services will see the main focus of their elective activity increased on the Hemel site, and that will include respiratory, cardiology, dermatology, pediatrics, and care of the elderly. We are hoping to enhance technology and improve diagnosis and provide faster diagnoses through investment in enhanced scanning and imaging equipment, including MRI, CT, and DEXA scanners. The outpatient facilities will not only be refurbished, but they will be redesigned in order to provide a more bespoke, specialty-based environment to provide more effective care in such a way that the multiple clinic visits will be reduced, and there'll be a greater emphasis on one-stop experiences where patients might come in and in addition to an outpatient consultation, have some diagnostic tests and hopefully discussion of the results of some of those diagnostic tests as well. The environment is being enhanced to improve the overall health and well-being, and just provide a better environment for discussing long-term conditions for chronic sufferers. We've also designed in spaces so that we can facilitate multidisciplinary meetings for staff, and we're hoping that the whole package will eventually become a model of really good planned care, and how you can deliver that in a multi-specialty site. Next slide, please. So, as I said, a number of specialties are going to be expanding its level of activity on the Hemel site, and that's going to include cardiology, dermatology, diabetes, endocrinology, and rheumatology. Pediatrics, care of the elderly, and frailty assessments will also be enhanced on this site. But the services are going to be redesigned so that all of these specialties can interact together and also manage their own specialty activity in an enhanced way, not just a standard outpatient appointment. As already outlined, a number of dermatology patients will see their activity translate from Watford to Hemel, and it's going to be the main clinical hub for specialist diabetes services. So next slide. So as an example of the kind of things where we're designing, I can give you examples of what's happening in rheumatology. We're moving the bulk of our activity from Watford and Centaurban's and focusing it on the Hemel Hempstead site. But we're not just simply lifting and shifting existing services, but it's part of a complete service redesign, which is being underpinned by more bespoke accommodation. And for example, in addition to refurbished outpatient space, where we've designed in an acute assessment ward with day case facilities to administer injections and infusion therapies. It offers a space for us to see patients urgently and almost run a mini rheumatology emergency unit where we can inject joints and offer enhanced treatments and assess patients very urgently. We are focusing and expanding our DEXA scanning capability there and expanding our metabolic bone unit so that we can offer a broader range of bone expertise. We've designed in some R&D space so that we can have a greater rate of enrollment of our patients into clinical trials, so that our patients get access to the latest developments in rheumatology. We've also designed in video conferencing facilities so that we can liaise with other regional and even national centers, so that we can run the national trends in rheumatology is one of multidisciplinary meetings where tertiary centers combined with district general hospitals, so that the most experienced super specialties can be involved in the care of our local patients. So we really are focusing on getting the best clinicians countrywide to have involvement in our complex rheumatology patients. We've also put in spaces in our plans for special interest groups where we can bring patients in, and there would be adequate space for education events, group clinics, and I know we've got a number of community special interest groups for rheumatoid arthritis, patient groups on ankylosing spondylitis, Sjogren's and lupus, and we're hoping to be able to have the kind of facility where we can run education events and really offer out of hospital care for these patients to help them live with their disease. And then finally some meeting rooms where we can have MDTs with other specialties. So our patients don't just have joint disease; they can develop lung disease, they get anemia, etc. And having close liaison with the other medical specialties and having that synergy between the medical specialties is a really important aspect of care that can be lost in the setting of a really busy emergency hospital. So I'm sure the other specialties will be working in a similar way with that kind of development as well. And other things to mention would be care of the elderly and a combined multidisciplinary and multi-agency approach to their management. Currently, a lot of this kind of work is done in the inpatient setting, and the setting of a busy emergency hospital is not the ideal way to plan people's long-term care and coordinate with mental health, community services, social care services. The idea, and this is being rolled out worldwide, is to take a proactive approach, catch these people who have complex needs, and attend to their needs before they reach a stage where they decompensate so much that the only place for them is the acute emergency hospital. Next slide, please. So at Hemel and Sach, the service offering is going to be very different but complementary. So at Centaurban's, the surgical specialties will coalesce on that site, and most of their outpatients will be centralized, moving from Hemel and from Watford to the Centaurban site, where to create a really combined, strong planned surgery and cancer service. Gastroenterology is slightly complex because they have mixed needs. They have a lot of medical patients, they have a lot of emergencies, and they have to liaise closely with surgery because they do a lot of cancer work as well. So they're going to continue to spread across 3 sites at this stage. The endoscopy facilities at Hemel Hempstead, I think everyone recognizes they are below par. They're restricted in size and they need improvement. And because of their codependence with the surgeons, that unit will move to the Centaurban site along with cystoscopy. And it's going to form a key part of an integrated cancer service model, which will be located at Sach and enhance the kind of one-stop model that is the aim for many conditions. Next slide, please. So I've been a clinician in West Herts for about 20 years, and I spent the first 2 working on the Watford site, a busy district general hospital. I was running clinics and at the same time trying to manage an emergency workload. In 2004, I started to do clinics at Hemel Hempstead, and I've been there ever since, and I'm really invested in Hemel Hempstead, and it really is one of the best part of my working week, because I think it's a different mindset. When you're in a busy emergency hospital, the acute needs of the emergency patients override everything else. But when you have a day in a much calmer, more personalized environment for the clinician, it's a better experience. But more importantly, I also believe it's better for the patient. You can argue that an environment where we're having to negotiate a 2,000 car park going into the bottom floor of a 16-story building where you've got 16 stories of sick patients isn't really the ideal place to talk about long-term disease management and patients' futures and how they're going to live with their disease and how you're going to manage them. So we were not directed towards Hemel Hempstead, but I think all the rheumatologists got together and we decided that actually we would rather have our unit based off the emergency site, both for our and our patients' best needs. And it was felt to be a site where we could develop the service in a really bespoke way to offer best care for rheumatology patients. And I think a lot of other specialties dealing with long-term conditions also feel the same way. So the proposal for Centaurban City, as outlined, it's to broaden the range and volume of surgery that is offered, including surgery that was previously on the Watford site. There is going to be upgraded imaging also, including MRI and CT provision to enable faster diagnoses. There is going to be an offering of nuclear medicine capability, which sits well within the overall service model of cancer care. It's going to become the location for a new endoscopy support unit to support the cancer care and the other specialties, and also the focus for hepatology services as well. It will provide some form of urgent care service, but the exact type and level is still undergoing review. And it will be a location for an increasing number of one-stop clinics and clinics such as the one-stop breast cancer screening service are really a role model for a really successful day case facility, avoiding the need for hospital visits, multiple hospital visits, etc. And it will also offer cancer support care as well. Next slide. So as outlined by Freddie Banks, our senior consultant urologist and associate director for strategy, Freddie pointed out that historically it's been a real challenge to manage certain conditions such as prostate cancer, because diagnostic facilities were separate from clinic facilities, and the different specialties were sitting in different areas. And now we have the backing of a proper redevelopment project that will give us with the right facilities. It becomes that much easier to generate more coherent patient pathways, which eases the journey for the patient. They're not going to multiple places, and they're achieving a faster diagnosis and overall a much better experience. Watford General, as you all know, is going to have extended and improved emergency and specialist care services. It's going to be the centre for emergency management and a big acute inpatient admission service. High-risk surgery is going to be carried out on that site. The critical care services will obviously be focused there, and all diagnostic and treatment procedures where there is significant risk, because the backing of full on-call services underpins those procedures. So it'll therefore be the Centre for Complex Diagnostics. There'll be a fracture clinic adjacent to the emergency department. There will be a lot of multidisciplinary meeting spaces just to carry on that model of interdisciplinary communication and inter-site communication. There's going to be a new big multi-story car park, and new specialist services are also going to be developed in order to support the increasing inpatient workload. And that's going to include inpatient neurology, inpatient chemotherapy, and some additional cardiological processes. And there is a drive to drive West Herts as a DGH plus and reduce the need for tertiary care referrals and manage more patients locally, and having really good revamped services will really facilitate that. And Watford would also be the centre of women and children's services, where high risk and low risk maternity will be focused, neonatal care, children's inpatient care, surgery, and specialist gynecology will be focused on that site. So Vicky Houghton, our intensive care matron, really crystallized how all the staff in West Herts feel after a really difficult 12 months. It's been difficult because of the COVID pandemic, and it has taught us how important it is actually to have facilities which you can actually keep COVID free. But we have, of course, been challenged by the state of our facilities and our estate, and all the staff are really looking forward to having new and improved facilities and to have this redevelopment project started soon. It's going to be a huge boost to morale. Thank you.
Thank you very much. Thank you. That was great, Sandeep, and very interesting, particularly for people who've been putting in questions, because I think you've already answered some of them, but we will pick those up. So I'll be quick so we can get to your questions. So this is the engagement plan, our timeline. You can see we're coming towards the end of our period of public engagement. We will feedback everything that we've heard, whether it's from comments via the chat functions to meetings like this or via the survey. So once we get past the 24th of March, we will consider all of your comments and your feedback. And that feedback is very useful for the board. They will use it to inform their decision making, and it will also help us when we are looking at the clinical brief. So thank you for being here tonight and being part of that feedback. It's really important. So just coming on to the next slide, which tells you a little bit about the survey. It's important for us to make sure that that's impartial. So we've gone to a third party to devise the survey. They will also analyse it, and they will feed back the results to us. So that will come from a third party, so it has some independence to it. And then the next slide is just a reminder of how you can get involved. We still do have a little bit of time if you want us to come out and make a presentation to any groups that you're a member of. And hopefully you still have time to read some of our documents and to take part in the survey before the 24th of March. So over to questions now, and thank you for submitting them. We do have quite a lot already, so I'm going to try and ask questions that really do relate to Hemel Hempstead, because that's the model of care that we're talking to you about tonight. So I'm going to start with the Hemel Hempstead questions. Sandeep, I think you've already given us the list of the services that will be provided. And on that note, I should say that they are available in the clinical brief document. So if you didn't catch up with that list, it's quite a long list because there are many services that are going to be provided. I would urge you to look at the clinical brief document, which will show you all the services that are going to be provided at Hemel Hempstead Hospital. But the question for you, Sandeep, is around the one-stop clinics, and how realistic is it, do you think, that somebody can have more than one step of their care provided? So is it really going to be the case that a diagnostic procedure can be carried out and then the patient can immediately see a nurse or a doctor or another clinician?
Yeah, I think that it's not additional work to do a one-stop service. It's a better way of just redistributing the work. So we already do certain limited one-stop things, like if patients come to clinic, we would send them for an X-ray, and we would do some investigations and then bring them back up on that same occasion. But if we're looking at things like synovitis, a lot of services, and including our one, will be having in-house facilities where if we see someone with some joint swelling, we can get an ultrasound scan done in the clinic, so that we don't have to send them off to radiology and then rebook them 3 weeks or 3 months down the line, it's not effective care. It's far better and it's more economical in terms of our time and the patient's time. So it's certainly doable. It needs some planning, it needs the facilities, and it needs support from the trust, both in terms of facilities and finances. But it is really the model of care for managing things like synovitis and a host of other conditions.
Thank you. So one of the questions is, please confirm the potential for one-stop clinics at Hemel Hempstead Hospital. I think you've probably been doing that for the last 20 minutes. Do you feel confident that we can provide more care along that model at Hemel Hempstead Hospital?
Yes, yeah, absolutely. I think with the focus, because of the COVID pandemic, we've been doing a lot more virtual work and really using technology. And I think once we get electronic records, etc., we will be in a kind of position to offer that kind of service far more extensively. But we have to really, because there's an expanding workload. We have to look at new innovative ways of managing the workload. And even if it's not one stop, but it may certainly be one visit followed by a virtual follow-up a few days later with the results. So it will be one stop for the patient, but it will. There may necessarily be some delays for results to come through, but we have to work that way in order to manage the workload.
Thank you. Claire, I'd like to bring you in, please, to answer a question that I have about basing secondary, primary and social workers and third sector staff at Hemel Hempstead Hospital. I know when Sandeep was speaking, we heard about a new cancer information centre at St Albans, so how we would like to bring in, so that might be third sector or Macmillan. So we've heard about that model at St Albans, but do you think that there is possibility of staff other than hospital staff being based at Hemel Hempstead Hospital to support our patients?
Yes, yeah, absolutely, definitely. So we're having lots of conversations at the moment with our primary care colleagues to look at how can we use the opportunity that Hemel gives us to really start to integrate the way that our primary care GPs work with our acute consultant specialists, so that we can join some of that care up better. Because obviously people who are coming into the trust with long-term conditions are often in very regular contact with their GPs. So we are looking at what that might look like, how we might do it. The location obviously would follow from that. But I think looking more widely, we already in primary care are able to signpost people through what we call social prescribing to third sector organisations who are able to support across a wider range of people's issues rather than just purely their health issues. So that there are lots of things where other parts of people's lives impact on their health. And so I certainly think there's lots of opportunities for the third sector social prescribing to help people to support and manage their long-term conditions. So it's early in the development, but definitely lots of potential to bring some of those things together.
Thank you. And don't go away just yet, because I have another one which has got your name written all over it. Do you think that services from the Marlows, which are provided by another organisation, and perhaps you could explain a little bit about that, but do you think they would ever move into the hospital at Hemel Hempstead?
We're actually having a conversation along those lines earlier today, by coincidence. So for people who don't know, the Marlows is a community service, or a building offering community services very closely located to the Hemel site, and it has a range of community services, mental health services within that building. So it's a bit early to say. There aren't any current plans to bring those services on the site, but we are intending to have conversations with the organisations who provide those services to understand what opportunities there are to better integrate with some of the services on the Hemel site, what their longer term plans are. So there aren't any immediate plans, but we are definitely aware of those services and would want to bring them together and integrate them as best we possibly can.
Thank you very much, Claire. Mike, I'd like to ask you a question, please, about endoscopy. Well, there's two questions. So the first is from somebody who thought that the endoscopy facilities were upgraded recently. And then there is another part to that question, which is about endoscopy being more than just a procedure to rule out or detect cancer. So if you could just describe a little bit about the facilities, a recent upgrade, and what the clinical purpose of endoscopy is, that would be great. Thank you.
Thanks, Louise. Yeah, so we have been doing some limited upgrades to our endoscopy units and to do with patient safety and some MRI facilitation with regards being able to accurately steer the probes inside the body. But I think it's more important to focus on what the future is. So as Sandeep alluded to earlier, and also within the slide presentation, we've been pursuing a policy of repatriation of specialist procedures from tertiary centres back to West Herts. And we are already one of very few trusts that do what's called EBUS and EUS, where you have ultrasound guided biopsy through an endoscopy tube. And that can be both within the lungs and within the intestines. And one of the things that we're really proud of is just going back to the one-stop service for EBUS, which is used primarily to diagnose lung cancer. We actually have a cytologist in the endoscopy lab, so that when the endoscopies occurred and they've done this ultrasound guided needling of the lesion, they can actually look at the specimen there and then on the spot to make sure that they've actually needled the correct area and make the diagnosis there and then. That is quite a phenomenal service. And as our gastroenterologist will frequently remind us, is that they've actually achieved what's called Jag Accreditation, which is the highest level accreditation for endoscopy services. And we can see this service continuing to expand and improve, particularly with the increased digital technology we're going to have, but also to have the layout to allow us to expand the complexity of the work that we currently perform and in a far more comfortable environment, both for our staff and for our patients.
Thank you, Mike. So while I've got you, I'd quite like to ask you a question, please, about pre-ops. And the question is, would there be separate pre-op assessments at each site, or would these be moved to a single base? And if Hemel does urgent and planned surgery, that's not quite, yes. I'll just stick with the first part of that question because I'm not quite sure I'm clear on the second part. So it's about separate pre-op assessments. Will they be in one single base, or will they be at the hospital where we expect the patient to continue having their care?
So I think, to be honest, we haven't gone into the detail yet as to where we're going to be having these pre-ops, but part of the focus of the new way of working is that we try and provide services close to patients' homes. What I can tell you with regards pre-op is that we are now have introduced a new electronic pre-operative assessment methodology, so that everybody gets precisely the same agreed way of assessment. And what is good, and it's been particularly good with the pandemic, is that you can set review dates at the time of seeing the patient, so that if the patient exceeds that waiting time, they are automatically flagged to the relevant clinicians, who can then do a review, we call it a harm review, to make sure that the patient is not coming to harm because their wait has been extended. And we know that during the pandemic, unfortunately, waiting lists have been significantly affected. And that can be customized to the procedure. So if, for instance, it's a hip replacement, you might say, well, that patient can wait longer than somebody who is waiting to have their gallstones taken out, or a pacemaker implanted, or a coronary stent. I think with the advent of virtual medicine is also going to change a lot change the way we do pre-op assessments quite considerably. There will still be obviously the hands-on examination and chatting to patients, but a lot of the counselling and further workup can be done from the comfort of the patient's home, with the clinician interacting with the patient in a virtual setting.
Thank you. And one more, Mike, while I've got you. As a cardiologist, could you explain how a patient might benefit from having their care under a one-stop clinic model?
Yeah, so if you look at the current model, we will get a referral, and we may think that the patient needs to have a certain test done or phone them to get that assessment. And then they will come along, they'll have one day they'll have an echo, and then another day they'll have a 24-hour blood pressure monitor, and then another day they'll have a 24-hour ECG, and perhaps on a fourth day have a chest x-ray, and then finally come and see you in the clinic. If we have this integrated system in place, we would probably do that initial virtual consultation to see how urgent the test needs to be done and what we think needs to be done. And then by having the electronic systems in place, they would come along, have the chest x-ray, the 24-hour ECG and the 24-hour blood pressure monitor all fitted the day before they're due to be seen. And then on the day that they are going to be seen, they drop those monitors off, which will be analyzed while they're having their echocardiogram. And then 60 minutes later, see the doctor with the results of all 4 investigations now being available. So it'll be a faster service, it'll be a more efficient service, and a far better patient experience.
Thank you very much. Thank you. Claire, we were hearing Mike talk about follow-ups and using technology to make sure that we have follow-ups and harm reviews. But there is also another way of managing follow-ups for patients who might not need that level of safety wrapped around their treatments, and it's more about choice. So could you say something, please, about patient-initiated follow-ups, particularly through the lens of services at Hemel Hempstead?
Yeah, absolutely. So at the moment, lots of our patients come back regularly for follow-up appointments with their consultants. And the problem with that at the moment for people with long-term conditions who might be coming to Hemel is that often they're coming back at a time when actually their condition is fairly stable. And what that then means is that when their condition is less stable and they're having problems, they haven't necessarily got the ability to go and see a specialist at that time. And that often then means that their health deteriorates and they end up coming into accident and emergency department. So the opportunity, what patient-initiated follow-up does is it puts the control with the patient to decide when they need to have access to somebody and when they need to be followed up, so that they can then contact the service, make an appointment and come and see somebody at the time that they need it. So it can work really well for long-term conditions in that way. It can also work well post-surgery. So people often are given a follow-up appointment post-surgery, and often it's just to check that everything's okay. So again, you can turn that round and say, well, if everything's okay, then you don't need to come in. But if there are any problems, get in contact and then we can arrange an appointment. So it moves control over to the patient and hopefully therefore allows them to manage their condition better.
And one question that we've had on a couple of other sessions as well, it's a really good question. And Mike, I'm going to come back to you if I may. And it's what's stopping us from doing this now? People are now excited about the one-stop clinic model, and they want to know, why can't we move to this immediately?
So a lot of it is to do with facilities, space, and having the digital ability to coordinate all these together. So there is some of this happening already, as Sandeep alluded to. But it is having the space and the facilities and vitally the IT support to get this, to be able to do this. So, I don't think we're going to wait until the new hospital opens before we do that. It's going to, I think from November onwards, when our electronic patient record comes online, we'll be able to start doing this to an increasing extent.
Yeah, and just a plug for the strategy. So the clinical strategy document does set out the things that we want to do over the next 5 years, and there's a lot that we want to do. It would be really helpful to get feedback from people about what you think is most important. So as Mike said, there are some limitations in terms of digital and estates that may not mean we can do everything, but it will help us to prioritise if we have a sense of what's important to our patients.
Yeah, and I suppose I can follow on with that. I mean, we've got huge plans for our frailty service. So we know from various models throughout the world, that you can, by coordinating and increasing preventative medicine in patients who've got multiple conditions, is dramatically reduce the number of admissions. And you can imagine, you know, a patient who's fairly elderly, has got 4 or 5 long-term conditions. At the moment, if they are being seen, they're coming to the hospital 4 or 5 times every couple of months. And looking at some of the models of care and analyze them, we know that if you can get those patients seen by either consultants or specialist nurses or GPs with a special interest on a regular basis, perhaps even monthly, where they get seen, their medication is titrated, their bloods are done, they see the podiatrist, they see the physiotherapist, that by having the IT in place, they can do this on a single visit once a month. They come along and they see the endocrinologist, the diabetologist, they will see the cardiologist, the COPD nurse, and perhaps the Parkinson's specialist. So they get this complete virtual MOT being done. And some of the models in America have reduced up to 70% of admissions. If we could do that to for our patients, it would absolutely transform care within West Herts.
Thank you, Mike. And Sandeep, I'm going to come to you because it sounds like from your career that you were describing that you've spent more time working at Hemel Hempstead than at Watford, and we've been hearing how Hemel Hempstead will be very much outpatient based care. So do you believe that a great hospital, like your quote, can be a hospital that has no inpatient beds?
Yeah, I think it's. I think medicine has moved on in the last 20 or 30 years. I think with our increased capabilities, our ability now is to prevent disease, and to an extent where I would view it as a failure of my elective management if a patient with a known diagnosis comes in decompensated and we can achieve it. If you think 20 or 30 years ago, and Mike will back me up, that the treatment for a heart attack was 6 weeks of bed rest in a hospital, and now the advent of drugs, etc. I think just like all other fields of life, the hospital inpatient stay will be the last resort. I mean, it's nice to have a really nice new hospital on the Watford side, but nothing is better than not going into hospital in the first place. And I think, and if you look at all of the specialties, they've expanded huge amounts. The number of consultants, when there just used to be 1 cardiologist, there are now 14 cardiologists. And it's the same for all specialties. And it's not because beds have increased 14 times. It's because our elective work has increased there with the number of specialties. The amount of sheer volume of work that we do in the outpatient setting is what drives most specialties. And I think certainly we should be changing the definition of hospital out of inpatient care, which is emergency care, into more of an elective environment.
Thank you. Mike, I have a question about diagnostics and whether they will be 24/7. So perhaps you could give an idea of what you expect there to be at each site, and that will also pick up another question about MRI at Hemel Hempstead. Thank you.
Okay, so I mean, as these facilities, let's start with Hemel. So Hemel is going to be elective outpatients and day case facilities. So, we're not going to be running 24/7 complex imaging on that site. But we will be having MRI and CT there, and including complex CT and complex MRI, such as cardiac MRI and cardiac CT. So that patients who don't need to go to the hot site, so to speak, don't go there. At St. Albans, the complex imaging will be available during the day, and I think we will be having a system where emergency stuff could be done after hours. But if we've done good grading of the patients and assessment, it's unlikely you're going to be using the specialist imaging after hours, and therefore it would probably be a more economic model that, you know, if 1 or 2 CTs are needed after hours in a year, it'd be better to move the patient rather than to have somebody on call for 365 days of the year and only be utilised once or twice. Clearly, Watford will be 24/7.
Thank you. And I've got a question about multi-storey car parks, so I think I can answer that one. And the question is, will it have fewer spaces for patients than the existing one? Well, there isn't an existing multi-storey at Watford at the moment, but we do plan to provide more spaces when the multi-storey car park has been finished. So that's more spaces than there currently are. And within that, a higher ratio of spaces for blue badge holders. And there will also be enhanced drop-off. So there's going to be a huge piece of work around access in, access out, and drop-off and parking at the Watford site. I have a question about ophthalmology, and possibly Claire, I'd like you to speak to that, because I know there's a lot of work around ophthalmology that now means that a lot of services are provided in the community. So the question is, where will ophthalmology be provided from? Thank you.
Okay, so ophthalmology is a surgical specialty, so we would expect the majority of that to be at St Albans, which I think is where it is at the moment. There are some elements of ophthalmology at the Watford site as well, but generally speaking, it's a planned specialty rather than an emergency one. So the majority would be at St Albans. As you say, there is quite a lot of community provision now, and we would expect that to continue. There aren't any plans to change that community provision. It's working very well.
Right, thank you. Completely different now. I've been asked a question about the survey and whether or not it was co-produced with patients and the public. So it was produced independently, and I do know that the company who did that for us spent several days user testing it. So, so it has been tested before being launched, and further methodology can be found on our website. You can find the details of the company who have provided that service to us, and they will set out their methodology. But yes, it absolutely was road tested before we launched it. There's a question here about not being able to see the questions that you're all sending in, and this is just we've chosen to run it this way for ease, really, because I can see all the questions and can work out where they have overlapped or duplicated. So there's not any sort of great reason for secrecy, other than it helps people focus on what they're listening to and what they're looking at, rather than scrolling all through the chat. The important thing, I think, is that you send in your question and we will do our level best to answer it. I think we've talked about one-stop clinics and which kind of conditions. So I would urge you to read the clinical brief if you really want to, you know, get on top of all the detail. That's the place to go, not forgetting the strategy document as well. And a question here about patients with hearing issues, and so who need help with hearing aids and batteries. So it would be important, I think, to stress that a lot of services, local outpatient services will still be, or a range of outpatient services will still be provided, because you realise that for many people, they need those at the hospital most local to them. So blood tests is a service that we envisage being provided locally still. But I don't know, Claire, if you want to just explain a little bit about the split, because we do know that a range of local outpatient services will still be provided across all 3 hospitals.
Yeah, so as we've sort of talked about already, we do want to try and consolidate our staff and use them to the best effect. And I think that somebody's already spoken quite a bit about the benefits of doing that. But as you say, we are aware that there are some specialties which are very high volume, or which it's particularly important to keep locally. And as you say, blood tests is a really good example of that. So for a small number of services where the volume justifies it, we will keep those on all 3 sites. And that's, again, within the clinical brief document, it shows which are those services and which sites they will be maintained on.
Thank you. And a question, Mike, I know you've been very involved in the electronic patient record. There's a related question here about access to the summary care record. Is that something that our clinical staff have at the moment? Do you know?
So within this hospital at the moment, we do have access to our internal records, but we don't have great access to primary care other than an A&E and some other settings. And one of the things the EPR will be doing is to have an integrated electronic patient record across all sectors. And so the GPs will be, if they refer a patient to the hospital, we'll actually be able to follow the progress of their patient whilst in hospital. And the patient will also have access to their own records, both in hospital setting and an out hospital setting. So, you know, we need to move away from a situation of secondary care, community care, primary care. We want to have integrated care. So everybody can see everything. And that way we don't duplicate things, we don't delay things, and we improve our efficiency and our patient care.
Thank you. Sandeep, you talked about some intravenous treatment at Hemel Hempstead, and I've been asked a question about intravenous antibiotics and also dialysis, so renal dialysis. Are you able to explain what kinds of intravenous treatments you envisage being provided at Hemel Hempstead? And maybe, Mike, you can come in about the renal dialysis, if you want to maybe address that first, Mike, about renal care.
So renal care, we are reviewing the situation at the moment. We currently have 2 different providers providing dialysis, depending on which part of the catchment you're in. And so we need to have an integrated plan. And I know our Divisional Director of Medicine is having in-depth discussions as to where we should be providing this, how we should be doing it. Do we try and centralize it into a single unit, which clearly from an efficiency point of view would be easier. But a lot of these patients are quite frail and elderly. So we haven't made a final decision yet about that. That is still under review. I'll hand over to Sandeep about the IV side of things. It's not just, I just remind, it's not just intravenous antibiotics. It's also heart failure treatment when they receive intravenous diuretics.
I think all specialties have seen a rise in the kind of capability to treat, and a lot of these treatments, particularly in our specialty, are biologic, which means that they're proteins rather than chemical drugs, so they have to be administered intravenously. So we have a range of immunosuppressant and immunomodulatory treatments. All of the new kind of advanced osteoporosis treatments are also intravenous as well. So in our specialty, there'll be predominantly that kind of thing. But then in specialties like hematology, there'll be biologics, but there might be the potential for infusing blood products, etc., blood transfusion, and as Mike said, intravenous antibiotics. And but I think all specialties will have a range of drugs that could be administered intravenously on the Hemel site.
Thank you very much. So that brings us to the end of tonight's session. I'm very grateful to Claire, Sandeep and Mike for being with us. We've got through very many questions tonight, so thank you for keeping us on our toes. I hope you will continue to join us at our 6 p.m. sessions, and I very much hope you will find time to read our documents and to do the survey. Wishing you the best of health. Good evening.